Bismillah ar-Rahman ar-Rahim. Our topic today is gastroesophageal reflux disease and hiatus hernia. I am Professor Muhammad Al-Ruwaini, Professor of Surgery, working at the VIT Surgery Unit at the Faculty of Medicine, Alexandria. The objectives of our topic today is definition of gastroesophageal reflux disease, epidemiology of gastroesophageal reflux disease. We will discuss the pathophysiology and the etiology of gastroesophageal reflux. We will state the different clinical manifestations. We will elaborate about the diagnostic evaluation and diagnosis. The different types of treatment will be mentioned, the complications of the disease, and those which occurs after surgery or medical treatment. Gastroesophageal reflux disease has been used to be defined as any symptoms or esophageal mucosal damage that results from reflux of gastric acid into the esophagus. The acidic nature of the refluxed gastric content and the presence of the enzyme pepsin is predominantly responsible for the esophageal damage and the development of reflux esophagitis. However, recently it has been shown that the presence of bile in reflux contents is increasingly thought to contribute to reflux disease in a subset of cases. Bile refluxate contains bile acids and trypsin. This is why recently the American College of Gastroenterology guidelines define gastroesophageal reflux disease as symptoms or complications resulting from the reflux of gastric contents, not gastric acid only, gastric contents, as it may contain other constituents than acid, into the esophagus or beyond, into the oral cavity or the lung. With the definition, it is interesting to know the classical gastroesophageal reflux disease symptoms, which are two: heartburn, pyrosis, which is a substernal burning discomfort, and regurgitation, which is a bitter acidic fluid in the mouth when lying down or bending over. This is why, because when we say we have heartburn or we have regurgitation, it may be synonymous of gastroesophageal reflux. Also, it has to be known that certain nomenclatures are important in the gastroesophageal reflux disease: erosive esophagitis, non-erosive reflux disease NERD, and Barrett esophagus are three phenotypic presentation and nomenclature of gastroesophageal reflux disease. Erosive esophagitis, when the gastroesophageal reflux disease is accompanied with erosions and ulcerations of the gastroesophageal mucosa, of the lower esophageal mucosa. Non-erosive reflux disease occurs when the patient has symptoms, but on endoscopy there is no erosions and no pathology seen on endoscopy. Barrett esophagus occurs when the inflammation of the lower esophageal mucosa leads to metaplasia that change the squamous epithelium of the lower esophagus into columnar lined mucosa of the lower esophagus. And this is part of the definition. It is interesting to know that physiological gastroesophageal reflux occurs, and all of us and any individual has experienced some gastroesophageal reflux, some heartburn, some regurgitation, and this is physiologic when most of the time it occurs postprandial after a big fatty meal. It is characterized by being short in time. It does not occur for a long time. Most of the time after that, the patient is asymptomatic, not complaining of these symptoms all the time, and it does not occur by night, awakening the patient of his sleep. On the other hand, the symptoms when the symptoms are present for a long time, daily or more than a day per week, and the symptoms are annoying, when there is mucosal injury on endoscopy, when symptoms occur by night and awakens the patient from his sleep, this at this time we can speak of pathologic gastroesophageal reflux disease. The incidence and the statistics we have from the United States. 44% of the population had experienced at least once per month of heartburn. Per week, 14% experienced this. Most of those, we can classify them in the group of physiological gastroesophageal reflux. Those who have symptoms daily, annoying symptoms, represent 7% of the population, and those who are concerned by the gastroesophageal reflux disease. This is why, when the symptoms are mild and recurs infrequently, the patients does not seek medical advice, and most of the time they can take on-shelf medication, antacids or H2 blockers. When the symptoms become more frequent, they may see a physician, primary physician, but when there is persistent symptoms, annoying symptoms, complications, most of the patients go to see a gastroenterologist. The important reasons to diagnose and treat gastroesophageal reflux are its negative impact on health, related quality of life. The patient is annoyed by his symptoms, it disturbs his life, it prevents him from his daily activity, and he is not productive. So it's interesting to diagnose and treat this patient. Also, there is a risk factor of transformation of the columnar-lined esophagus, which occurs as a complication of gastroesophageal reflux, into an adenocarcinoma, and this is why patients with gastroesophageal reflux, when they are symptomatic for a long time, should be followed by endoscopy to assess their condition and to make surveillance of the occurrence of Barrett esophagus and adenocarcinoma. Regarding the etiology, the occasional reflux of gastric contents into the esophagus, as we said, is a universal phenomenon. It occurs frequently in the individual, in the population. And the majority of people does not develop gastroesophageal reflux disease. Why? Because of the intact anti-reflux mechanisms. Yes, there is mechanisms which prevent the reflux of the gastric contents into the esophagus, permitting the food, the drinks, the fluids to pass from the esophagus downwards to the stomach and prevent them from coming back, even if the patient is bending downwards or is lying down. These are the anti-reflux mechanisms which clear the refluxed contents back into the stomach before damage is done. What are the physiologic mechanisms that protects against esophageal acid entry? We have four main mechanisms. The clearance mechanisms, by which we speak about the peristalsis of the esophagus. When there is reflux into the esophagus from the stomach, this will lead to the production of peristaltic waves which will push the refluxate back into the esophagus. And this is the clearance mechanism, which is an important mechanism. Mucosal integrity, there is mucosal integrity because the cells of the esophagus, the mucosal cells, are bonded together firmly. There is no intercellular spaces permitting for the refluxate, whatever it is, acid, bile, pepsin, trypsin, whatever is, does not pass into the submucosal layers, causing inflammation. The lower esophageal sphincter competence. We speak by lower esophageal sphincter competence that this is the region where we suspect the presence of a lower esophageal sphincter which is competent, and this sphincter is the high pressure zone which prevents reflux of gastric contents from the stomach towards the esophagus. The fourth mechanism is the gastric emptying, which is an important mechanism because it permits to the contents of the stomach not to stagnate in the stomach, causing dilatation, over-dilatation, increasing the pressure of the stomach, leading to overflow of the gastric contents back into the esophagus, and this gastric emptying is an important mechanism because it permits the vidange or the emptying of the gastric contents from the stomach. When we speak about the lower esophageal sphincter, anatomically speaking, it has not been seen on dissection the presence of a sphincter-like structure at the gastroesophageal junction. So it's better to speak about a high pressure zone resulting from the constitution of this area, where there is the most important factor in this high pressure zone is the presence of an intra-abdominal part of the esophagus of at least 2 to 3 centimeters exposed to the intra-abdominal pressure. The intra-abdominal pressure exerts pressure on the on the intra-abdominal part of the esophagus, leading to increasing the pressure in this area. So, an intra-abdominal part of the esophagus is an important part of the lower esophageal sphincter or the gastroesophageal junction competence. The distribution of the muscles along the esophagus, normally in the esophagus we have 2 layers, the longitudinal muscles and the inner circular muscle, but in the area of the gastroesophageal junction and the cardia we have another third layer which comes to be added to the structure, to the muscular structures in this area, which are the oblique sling fibers which are present in this region, and they play as a sling, permitting increasing the pressure and the closure of this opening between the stomach and the esophagus. One of the most important factors also is that the esophagus passes through the diaphragmatic hiatus, which is formed by 2 crura, the left crus and the right crus, which surrounds the esophagus and exerts some pressure and a pinchcock action on the esophagus, leading to increase in the pressure and keeping the gastroesophageal junction most of the time not opened but competent, not permitting reflux of gastric contents. One of the anatomical factors also which is important is the phrenoesophageal ligament. The phrenoesophageal ligament is peritoneal reflection, parietal peritoneal reflection on the esophagus and on the diaphragm, which anchors the lower part of the esophagus or the intra-abdominal part of the esophagus in its site, in this location, anchoring it and preventing its sliding upwards towards the chest, where the thoracic pressure is negative and less than that of the abdomen. Also, one of the important factors is the entry of the esophagus in the stomach at an acute angulation, which play some sort of flap valve mechanism, which is the angle of His. Finally, from the anatomical point of view, we have the gastric rouget and gastric folds, which are increased in this area circumferentially around the cardia, forming a sort of plug preventing reflux of gastric contents. So, to sum up, we have the factors involved, anatomical factors, most of the anatomical factors involved in the normal prevention of reflux is the lower esophageal sphincter or the high pressure zone, its intrinsic pressure, its total length, and the intra-abdominal length of the lower esophageal sphincter. The angle of His, we explained, play as a flap valve mechanism. The crural fibers of the diaphragm around the esophagus have a pinchcock action, the mucosal rosette, which are the gastric rouget, which are prominent mucosal folds at the gastroesophageal junction, forming a sort of plug. For the clearance mechanism, we have the antegrade esophageal peristalsis, which propels, which push down any refluxate from the stomach, which occurs in the esophagus, pushing it back to the stomach, and the saliva plays also a role in the prevention of reflux esophagitis by causing neutralization and lubrication of the esophagus and neutralization of the refluxate. Normal gastric motility and emptying is important, as we said, because it makes the stomach empties its content, not leading to increase in the gastric pressure. So, symptomatic reflux will occur when this anti-reflux mechanism become impaired, such as in the case of a weak lower esophageal sphincter function or impaired esophageal clearance due to esophageal dysmotility, or the presence of a hiatus hernia, and when there is poor gastric emptying. The lower esophageal sphincter function is abnormal or poor when the length of the high pressure zone is small, when the pressure of the lower high pressure zone is low, and this will lead to improper function of the high pressure zone, or the lower, what we call lower esophageal sphincter. But sometimes we have normal pressure, we have normal length of the high pressure zone, but although of this we have reflux disease and reflux esophagitis. This has been recently explained by the occurrence of transient lower esophageal relaxations, which is till nowadays not fully explained, but these are relaxations which occur without swallowing, and the lower esophageal sphincter relaxes. This usually occurs by night when the patient is sleeping and lying down, and when this relaxation occurs, this will permit to reflux of the gastric contents and acid or other constituents to go to the esophagus. With this relaxation, with the patient in this position, this reflux or this refluxate will pool in the lower part of the esophagus, will act on the gastric mucosa, on the esophageal mucosa, causing some sort of inflammation and esophagitis. The poor esophageal clearance most of the time occurs due to motility disorders, and this is common in the elder population or in patients with achalasia, stroke, or collagen disease as scleroderma, as in these conditions there is improper peristaltic activity of the esophagus. The presence of a large paraesophageal hernia can cause slowed emptying of the esophageal contents or the refluxate when it occurs in the esophagus. This may be due to obstruction by the presence of the hernia and its size, and also the presence of the hernia will lead to altered motility of the esophageal peristalsis. Delayed gastric emptying, as we said, can be due to anatomic obstruction of the gastric outlet of the pylorus, as in pyloric stenosis, either due to healed duodenal ulcer or carcinoma at this area, which may lead to anatomical obstruction of the gastric outlet, or due to neuromuscular dysfunction, as in gastroparesis. This occurs in elder people and may occur also in diabetic patients. They have the diminished motility of the stomach. So, to sum up this figure, we'll show in the different etiological factors that play a role in or may play a role in gastroesophageal reflux: the impaired esophageal clearance, impaired salivary function, impaired esophageal mucosal defense will occur when the inflammation occurs by the refluxate. This will lead to opening of the intercellular spaces and introduction of the acid or the gastric refluxate into the deeper layer of the esophageal mucosa, leading to inflammation and deleterious effects. The presence of hiatus hernia, transient inappropriate relaxation of the lower esophageal sphincter, which occurs normally by night, gastric acid increase in the acidity of the gastric content, reduced resting pressure of the lower esophageal sphincter, delayed gastric emptying, and we can add the pyloric incompetence with duodeноgastric reflux, reflux of bile into the stomach that may reflux into the lower esophagus through the cordia. So, primary barrier to gastroesophageal reflux is the lower esophageal sphincter. When it works normally in conjunction with the diaphragm, there is no reflux, but if this barrier is disrupted, acid goes from the stomach to the esophagus. Some factors help or plays a role in relaxing the lower esophageal sphincter. We can mention food as citrus fruits, chocolate, drinks with caffeine, fatty and fried foods, garlic and onions, menthol, spicy foods, tomato-based foods like sauce, chili, and pizza. Those type of food will play on the lower esophageal sphincter competence and relaxes the lower esophageal sphincter and may play or may help reflux to occur. Pregnancy with the increase in the intra-abdominal pressure may play a role. Drugs as oral contraceptive pills, the hormonal content of these pills may also play a role, leading to diminishing the esophageal sphincter pressure. Smoking and obesity can also play a role in the occurrence and in the etiology of gastroesophageal reflux. The clinical presentations of gastroesophageal reflux, now we will discuss the different presentation of gastroesophageal reflux. We have three presentations. The classical presentation that we said before are the heartburn and regurgitation. Extraesophageal manifestations. Extraesophageal manifestations, we mean by that the manifestations are not related to the esophagus, the stomach, or the gastrointestinal tract, but this is why we say that there are atypical symptoms, but because they are not related to the gastroesophageal tract, and the symptoms of complications that may result from gastroesophageal reflux disease. The most common symptoms, as we said before, is heartburn and regurgitation. Heartburn is retrosternal burning discomfort. It is a classical symptom of gastroesophageal reflux. It is different from epigastric pain. It is different from dyspepsia. The patient describes it very clearly. I have some discomfort. I have a heartburn sensation beyond or posterior to the sternum. Regurgitation is different from vomiting. Regurgitation is an effortless act with return of gastric contents into the pharynx without nausea, retching, or abdominal contractions, which is different from vomiting. Vomiting is an active action with contraction of the stomach and contraction of the abdominal muscles. When these two symptoms are present, we speak about the classical symptoms of gastroesophageal reflux. So heartburn is a classic symptom. It is a substernal burning with regurgitation. It most of the time occurs postprandially. It can be aggravated by changing position, lying down or bending over, and there is prompt relief by antacids. The extraesophageal manifestations, we have manifestations related to the chest, manifestations related to the heart, and manifestations related to the ENT. The chest manifestations or the pulmonary manifestations most of the time are due to the refluxate which come up and can spill into the bronchial tree, and there is some sort of aspiration. These microaspirations can lead to deleterious effect on the bronchial tree and the lung, but also they can be the quantity can be big enough to make the patient awaken from his sleep, and the pulmonary manifestations in the form of asthmatics, repeated asthmatic attacks, aspiration pneumonia, chronic bronchitis, pulmonary fibrosis, and the patient is complaining of all these conditions most of the time. He goes to his doctor seeking for advice for a long time until we can discover that this may be due to his gastroesophageal reflux. Chest pain, some of the patients have chest pain because the lower part of the esophagus is sharing some vagal fibers with the heart, and this can lead to a referred pain from the inflamed esophagus towards the heart, mimicking chest pain and angina. The ENT manifestations in the form of hoarseness of voice, laryngitis, pharyngitis, chronic cough, globus sensation of a foreign body present at the pharynx, sinusitis, dysphonia, subglottic stenosis, and even laryngeal cancer. This explains what happens when the reflux spills into the bronchial tree and the lung by aspiration. These are the different pictures showing the effect of the reflux on the larynx and pharynx. The symptoms of complicated gastroesophageal reflux are dysphagia. The patient has difficulty in swallowing. He describes that the food stops or sticks or hangs up when he is swallowing, and he is in need to make some pressure to have drink to push the food back down into the esophagus. Odynophagia is different from dysphagia. It is a sense of pain. It is not a stoppage of the food. It is not sticking of the food. It is not hanging of the food, but it is a sense of retrosternal pain when the patient swallows, and this most of the time is due to the inflamed mucosa in the region of the esophagus. Bleeding. Bleeding can occur in gastroesophageal reflux. It's not a very common symptomatology, but it can occur either as an occult bleeding in the form of anemia or in the form of overt bleeding, whether hematemesis or melena, but this is usually really rare. If classic symptoms, we are now how to diagnose, how to deal with the patient coming with these symptoms, whether these symptoms are classic, whether these symptoms are typical, whether these are symptoms of complicated gastroesophageal reflux. When the patient comes, we have to manage the patient by setting the diagnosis and how to settle the diagnosis and to be sure of his diagnosis. If the classic symptoms of heartburn and regurgitation exist in the absence of any other symptom or any alarming symptom, his diagnosis of gastroesophageal reflux disease can be made clinically. You don't need to do any other investigations, and the treatment, empirical treatment, can be initiated. This is an important part to say that the heartburn and regurgitation are the classical symptoms. But if the patient has other symptoms, dyspepsia, epigastric pain, some dysphagia, some odynophagia, this is not the classical symptoms, and this patient should be investigated. But if the patient has clear-cut symptoms of heartburn and regurgitation without any other symptoms, you can start your medical treatment. So, diagnostic studies are not needed with classic history of gastroesophageal reflux, heartburn and regurgitation, when they are postprandial, postural, related to the position of the patient, and they decrease with antacid. No diagnostic study is needed, and you can start your empiric treatment. When these symptoms are present, these are the alarming signs, these are the alarming symptoms, dysphagia, odynophagia, bleeding, anemia, early satiety, vomiting, weight loss. When we have these symptoms present in conjunction with the classical symptoms, the diagnosis should be confirmed by diagnostic tools and diagnostic tests. So, when to perform these diagnostic tests? When diagnosis is uncertain from the beginning, you are not sure, you don't have the classical symptoms. When the symptoms are atypical, some of the patients, they don't have heartburn, they don't have regurgitation, but they have repeated attacks of asthma, they have ENT manifestations, they have chest pain, and after they go to the ENT doctor or the cardiologist or the pneumologist, after many times of visits to these patients, to these doctors, they may realize that they don't have a cardiac or a lung or an ENT problem, and they start to think about gastroesophageal reflux. In these cases, we have to settle the diagnosis by diagnostic tests. When symptoms are associated with complications, heartburn and regurgitation, but dysphagia, heartburn and regurgitation with odynophagia, with anemia, and so on. When these symptoms are associated with complication, we should do investigations. You started your empirical therapy for classical symptoms, but after 2 weeks, 1 month, your patient is not responding well to the treatment, so you have to stop and to make investigations to be sure of the cause of the disease and to be sure of the diagnosis of gastroesophageal reflux and to see why the patient is not responding to this therapy. Patients who respond well, but when they stop the treatment, they have recurrent symptoms, and when this recurrence of symptoms is very frequent, those patients should be investigated. Also, patients on treatment for a long time, 2 to 3, 4, 5 years, should have an endoscopy or an investigation to settle the diagnosis, to follow the patient, and to be sure that there is no complications occurring from the long-lasting gastroesophageal reflux. When we are going to decide to do surgery, it's good, it's important to make investigation before surgery. The diagnostic tests of gastroesophageal reflux, we have barium swallow, we have endoscopy, we have ambulatory pH monitoring, we have esophageal manometry. Barium swallow has its limitations because it does not show the detailed mucosa. It does not examine the mucosa as endoscopy. Before endoscopy, this was the best investigation, but nowadays, in the presence of endoscopy, barium swallow is coming back in the list, and because it does not show the mucosa perfectly as endoscopy, it does not show the erosive esophagitis, the Barrett's esophagus, so this is why endoscopy is preferred on barium. But it still has its importance in the cases of dysphagia, for example, to show a stricture. It can show its location. Endoscopy cannot pour us the stricture and thus cannot show and cannot see the length of the stricture that can be shown on barium. It can show masses. It can show the aspect of a bird's beak, as in achalasia, presence of hiatal hernia and its size and type, and when there is a short esophagus, this is better shown by barium. Endoscopic examination of the upper GIT is the mainstay of investigation of gastroesophageal reflux disease. It is not the best test to show and to quantify the amount of acid in the lower esophagus, but it is a mainstay diagnostic test because it can show the mucosa, it can show if there is any erosion or any lesion from the gastroesophageal reflux, whether ulcerations, whether erosions, and it can show some of the complication, columnar lined esophagus, and this is important. So it allows direct visualization of the lining of the esophagus and the stomach. But also it can take biopsies from the mucosa to facilitate histological examination of the tissues, especially when we are suspecting the presence of columnar lined esophagus, to show the presence of columnar lined esophagus, to be sure of its presence, to be sure that there is metaplasia, that this is an intestinal metaplasia, to be sure if there is dysplasia has occurred or not, low grade dysplasia, severe grade dysplasia, and if we are suspecting an area of carcinomatous transformation, we can take biopsies guided by the endoscopic examination. So, the indication of endoscopy, the presence of alarming symptoms, failure of empiric therapy, preoperative evaluation, detection, and surveillance of Barrett esophagus. The endoscopic findings in gastroesophageal reflux disease range from normal mucosa or the presence of erosions and ulcerations and other complications as Barrett esophagus. Based on the presence or absence of mucosal changes, gastroesophageal reflux disease is classified into 2 groups. The erosive esophagitis, when the endoscopy will find that this patient, with his symptoms, he has erosions of the mucosa or ulceration of the mucosa, and the other group, those who don't have any erosions on endoscopy, and those what we call non-erosive reflux disease, NERD, patient with symptoms but no mucosal lesions on endoscopy. What is a mucosal break? What is an erosion? It is in an area of slough or erythema with a sharp line of demarcation from the adjacent normal mucosa. This is important. The endoscopist should know how to see, how to detect an area of erosion. And according to this, we can classify the reflux esophagitis according to one of two main classifications. The older one is the Savary-Miller classification. This is the modified one, and the other one, newer one, is the Los Angeles classification. In Savary-Miller, we have erythema. This is grade 1, just erythema. Grade 2, you have linear erosions in the lower part of the esophagus, extending up from the gastroesophageal junction into the lower esophagus. But when these erosions become confluent together, one erosions is near the other, become attached to the other, this is grade 3, and grade 4 is the grade of complication when erosions are transformed and or accompanied by deep ulceration, or from the repeated attacks of erosions and inflammation, fibrosis occur and the stricture in the mucosa of the esophagus, or the esophagus occurs, not permitting the endoscope to pass and causing, for example, dysphagia, or when we have the suspicion of columnar lined esophagus. This is transformation of the squamous epithelium of the esophagus by metaplasia into columnar lined esophagus, because the squamous epithelium is not the best type of epithelium that can withstand the acidity of the refluxate, and this is why metaplasia occurs to make the lower columnar esophagus by metaplasia to withstand more the deleterious effects of the refluxate. But however, this columnar lined esophagus with intestinal metaplasia could be a source of adenocarcinoma if dysplasia occurs. So this is endoscopic pictures showing erythema of the lower esophagus. This is grade 1. This is an erosion of the lower esophageal mucosa. This is another one that are not confluent. So this is grade 2. Grade 3, if you look here, you have an erosion. This is another erosion, and they are confluent at their basis. This is grade 3. And grade 4, you have erosions, but you have a definite stricture in the lower esophagus, and this could be grade 4. The Los Angeles classification is similar. It's the presence of break or an erosion less than 5 millimeter in length in the lower esophagus. When these erosions are longer than 5 millimeter, this is grade B. Grade C, when two erosions are confluent together, but they don't take more than 75% of the circumference. This is grade C. Grade D is when the confluence of the erosions takes more than 75% of the esophageal circumference. The gold standard for detection of acidity and gastroesophageal reflux is the pH monitoring. pH monitoring can be for 24 hours and is ambulatory. The patient comes, we put a fine pH probe into the lower esophagus, connected to a recording device worn by the patient for 24 hours. It measures the duration, the frequency, and the severity of reflux attacks. It is the gold standard of quantifying the degree of reflux. Significant acid reflux is diagnosed when the pH is less than 4 for more than 5% of the time of recording, means 1.2 hour if it is 24 esophageal manometry, which is usually taken as an indicator for the importance of reflux, its severity, and the need maybe of surgery. This is the patient with the probe passes through the nose into his esophagus stopping at the gastroesophageal junction just 3 to 5 centimeters above the gastroesophageal junction, and it can detect the number of reflux episodes and their duration as on this figure. You can see this is the normal, this is pH 4, and we have no long attacks of reflux, but here you have a long attack of reflux below 4, which reaches below 2 pH 2 for a long time, from 11 o'clock p.m. to 2 o'clock of the morning. This is a long time of reflux, and this patient has reflux. Recently, instead of putting a probe through the nose, we can introduce with the scope a probe that we can hang and anchor to the lower esophageal mucosa by the endoscope, and we leave it inside the patient, and this will improve patient comfort and acceptance. He can continue his normal work activities and diet. We can record for a longer time, 24 to 48 hours, and this probe sends the informations to a battery and an instrument which records what happens and the pH all over the 48 hours. The manometry. Manometry has a limited role in gastroesophageal reflux, yes, but could have an important role because it can assess two important things. The one important is the lower esophageal sphincter, its state, its pressure, its ability to relaxate. Because a lower esophageal sphincter that does not relax will make us think of achalasia of the cardia. So in gastroesophageal reflux disease, we have good relaxation, but we could have a lower esophageal sphincter pressure which is low, and the length of the lower esophageal sphincter could be short. So manometry can assess this. Another important thing that the manometry can assess the peristaltic activity of the esophagus, and this could be important prior to anti-reflux surgery, especially in patients who have dysphagia. Why? Because patients who have dysphagia, if they have their dysphagia not due to stricture or to adenocarcinoma or whatever, but you do the endoscopy, you don't find any stricture or any mass or any adenocarcinoma, and some racema or one erosion, for example, this does not explain on endoscopy why the patient has dysphagia. But his dysphagia could be due to dysmotility that occurred from the reflux disease and the inflammation that occurs in the esophagus, leading to dysmotility. So those patients, if you do for them surgery with fundoplication, complete fundoplication, they will get more dysphagia after surgery. So with the manometry in this patient, you can tailor the type of surgery you will do for this patient, and we will explain it. But what I want to show you that on swallowing, there is increasing the pressure of the pharynx to push the bolus towards the esophagus, the upper esophageal sphincter relaxes, and at the same time the lower esophageal sphincter relaxes and maintains its relaxation until the bolus of food or drink passes to the stomach. And you have the peristaltic activity, which we call primary peristaltic activity. You have peristaltic activity in the upper esophagus, followed by peristaltic activity in the middle, in the lower third esophagus, and the bolus passes. And once the bolus passes, the relaxation of the lower esophageal sphincter returns to normal state of closure. So manometry determines the length and position of the lower esophageal sphincter. It measures the lower esophageal sphincter pressure and length, assesses the esophageal peristalsis and its propagation, Short or weak lower esophageal sphincter is a major cause of reflux esophagitis. A lower esophageal sphincter pressure of less than 4 millimeter mercury is abnormal and is an indication and could be an indicator for surgery. The normal lower esophageal sphincter ranges from 5 to 30 millimeter mercury. Differential diagnosis for gastroesophageal reflux disease, yes, gallstones, you can have epigastric pain, could be associated with some reflux, gastric lesions, gastritis, peptic ulcer, cancer stomach. They can lead to dyspepsia, epigastric pain, and can be should be differentially diagnosed from gastroesophageal reflux, and can mimic the aspect of gastroesophageal reflux and esophageal lesions, achalasia, cancer, the presence of a stricture, and coronary heart disease, as we said, anginal pain due to shared nervous fibers between both the esophagus and the heart. The complications of the gastroesophageal reflux disease, as we saw, we have erosions, ulceration, so erosive esophagitis, motility disorder of the esophagus, secondary to gastroesophageal reflux, esophageal peptic stricture due to repeated attacks of esophagitis and erosions and ulceration leading to fibrosis and stricture. This stricture could be amenable to dilatation, especially in the early stages when fibrosis is just in the mucosa, but if it passes to the deeper layers, to the muscles, sometimes dilatation does not give good results. Barrett's esophagus, which is the columnar lined esophagus, and adenocarcinoma. This is reflux esophagitis with some sort of stricture. This is a definite stricture seen on endoscopy and on barium. The stricture of gastroesophageal reflux most of the time is a benign stricture, which is central and regular, which is different from the stricture of adenocarcinoma. Strictures of the reflux disease most of the time are amenable to dilatation. We prefer pneumatic dilatation. Here is a stricture. This is a balloon. Pneumatic dilatation is by injecting air under force in this balloon, which will dilate. And if you see, this is the stricture, and this is the stricture after dilatation with some widening of its diameter. Barrett esophagus. Barrett esophagus is replacement of the normal squamous epithelium of the lower esophagus by metaplastic columnar epithelium due to long-standing reflux. This may be followed by the occurrence of dysplasia, whether low-grade or high-grade dysplasia. This is important to know. This is why we have to take biopsies, because if we have low-grade dysplasia, we will do surveillance of the Barrett esophagus. But if we have high-grade dysplasia, which is a predetermining factor of carcinoma in situ or adenocarcinoma, we should take an important step in the treatment, either by removing this part with high-grade dysplasia, or sometimes it can go to esophagectomy. This is a pre-malignant condition, 10% risk of adenocarcinoma. For diagnosis, intestinal metaplasia must be identified histologically and on endoscopic biopsy. Treatment is a combination in the early stages, and when there is mild dysplasia, there is acid suppression for lifelong endoscopic surveillance. Anti-reflux surgery may have a role, but if we high-grade dysplasia, other steps of treatment should be contemplated, even going up to esophagectomy. This is Barrett esophagus. This is adenocarcinoma with an ulcer with everted edges in the lower part of the esophagus, lower third of the esophagus, and this is the stricture of the adenocarcinoma seen on endoscopy. It is eccentric and it is irregular, giving rat tail appearance, which is different from the smooth appearance of stricture of gastroesophageal reflux. The treatment goals of gastroesophageal reflux, we can start with medical treatment. We have surgical treatment. Both of them have the tenets or the goals of eliminating symptoms, healing esophagitis, manage or prevent complications of the gastroesophageal reflux disease by treating the condition, and maintain remission, because if in gastroesophageal reflux disease, recurrence of symptoms is frequent and is common. The first step in the medical treatment is modification of lifestyle. It's an important part in the therapy. You have to learn your patient to elevate the head of the bed for 4 to 6 inches, avoid eating within 2 to 3 hours of bedtime, lose weight if overweight, stop smoking, modify diet by eating more frequent but smaller meals, avoid those meals which we mentioned before: fatty fried foods, peppermint, chocolate, alcohol, carbonated beverages, coffee and tea. On-the-shelf medications per nata when necessary. Pro-renata is when necessary. This means PRN pro-renata means when necessary, when needed. They can take on-shelf medication. Most of the time they are antacids. The second step in the medical treatment, which can be added to and should be added, to my opinion, to the modifying lifestyle, is the H2 receptors antagonist or is the acid suppression. This can occur or can be done by H2 receptor antagonists, but recently we have the proton pumping inhibitors, which inhibit the acidity of the stomach for a longer period, reaching maybe for 18 hours per day or more. So they are more effective. The proton pump inhibitors are more effective, and they are usually administered 2 days. You have a list of different types of proton pump inhibitors. The effectiveness of medical therapy is according to the type of treatment. Lifestyle modification only and antacids give 20% response. H2 receptors antagonists give 50% response. Single dose PPI can go up to 80%, and if you double the dose of the PPI, you may reach 100%. But if you have persistent symptoms, you have to be sure of your diagnosis. You may do investigations, and if the investigation shows that this is gastroesophageal reflux, you can improve the compliance. Be sure that the patient takes the medication regularly and at certain times. Optimize pharmacokinetics, adjusting the time of medication 50 to 30 minutes before meal, and consider switching to a different PPI or doubling the dose of your PPI. But gastroesophageal reflux disease is a chronic condition, and it relapses frequently. So esophagitis relapses quickly after cessation of therapy. More than 50% of patients relapse within 2 months. More than 80% will relapse within 6 months. This why there is importance of the maintenance therapy. You have to maintain those who recurs, those who relapse, on maintenance medical therapy in the form of PPI for a certain time or maybe for a long time. And those patients who we will keep them for a long time on PPI may be good indication for surgery. So when to discuss anti-reflux surgery? We will discuss anti-reflux surgery when we have gastroesophageal reflux disease requiring long-term PPI, maybe double dose, in a healthy young patient. If you have a young patient, he is fit, we expect him for a long time of life, so he will not be put on medication for all his life, and he may prefer to do surgery. And this is the best indication and the best results of surgery in gastroesophageal reflux disease. Those who have atypical symptoms, most of their symptoms are due to the regurgitation. The regurgitation is not treated by medical treatment. It can decrease, but it does not stop, because the PPI, it diminishes the acidity but does not prevent the regurgitation of the refluxate. The refluxate is no more acid but still is present. And as we said, that some subset of patients have bile in their reflux, they have bile acids in their reflux, they have pepsin, they have gastric contents. So those patients, if they have severe regurgitation, persistent regurgitation, aspiration symptoms to the lung, they will benefit from surgery. If you have gastroesophageal reflux disease, which is intractable, you give the treatment, but the patient does not respond, this is an indication for surgery, but they don't have the best results of surgery. When you have strictures that does not respond to medical treatment, surgery of anti-reflux surgery, your anti-reflux surgery will stop the acidity and will permit to the stricture to be better dilated or to manage the stricture surgically during the operation. Severe bleeding from esophagitis, non-healing ulcers, all those could be managed by surgery, and the presence of Barrett esophagus could be an indication for surgery to stop the ascent of refluxate. So, anti-reflux surgery patient preference if young and but he needs to stop his medical treatment, failed medical management, gastroesophageal reflux disease complications, atypical symptoms as we said before, medical complications attributable to a large hiatal hernia, those needs surgery. Anti-reflux surgery, the tenets of surgery, the idea of surgery is what? Is to bring back the intra-abdominal part of the esophagus, to restore the intra-abdominal length of the esophagus. If there is a hiatus hernia, to reduce it, to repair the hiatus of the diaphragm. Most of the time it's widened in patients with gastroesophageal reflux. You have to make it less wide, to strengthen the gastroesophageal junction, and by making an anti-reflux barrier by a gastric wrap, bringing the fundus of the stomach around the esophagus in a form of wrap, and this results in 75 to 90% effectiveness of alleviating the symptoms of the heartburn and regurgitation, and 75 to 90% of the patients are satisfied. So the principles of anti-reflux surgery, to sum up, is to restore the intra-abdominal esophagus. This is the most important part of the operation, is to reduce hiatal hernia if present, is to approximate the diaphragmatic crura to make the opening less wide, and to perform a fundoplication. This reflux surgery can be done transabdominally or transthoracic. Both can be performed through either open surgery or minimal access laparoscopic or thoracoscopic technique. Nowadays, laparoscopic Nissen fundoplication is the mainstay of surgical treatment of gastroesophageal reflux disease. The gold standard operation is the Nissen fundoplication. It is a 360 degree wrap in which the fundus of the stomach is wrapped completely around the lower esophagus. Following a hiatal repair means approximation of the crura of the diaphragm. Its complication, if we tighten the crura and we tighten the flap, the hiatal repair, the wrap, the patient can has dysphagia. So this is the laparoscopic technique. This is the introduction of the trochers. This is dissection of the fundus of the stomach by cutting the short gastric vessels and separating it from the spleen. Dissection of the crura and the gastroesophageal junction, bringing the lower part of the esophagus into the stomach, which have slided upwards, and if there is a hiatus hernia, to reduce it. Then this wide hiatus should be tightened by taking sutures, and then the wrap, the fundus, is brought about around the lower part of the esophagus for 360 degree. This is the classical Nissen fundoplication. So we have two types of Nissen fundoplication. We have the total fundoplication, which is the Nissen. It is a 30-60 degree fundoplication. One of its complications and one of its the problems that occurs after that is dysphagia. Dysphagia could be because the wrap is tight, and sometimes it is due to the dysmotility of the esophagus with bringing a wrap. This peristaltic activity is weak, you bring a pressure here by your tight trap, and this peristaltic wave cannot push the food, and this will lead to dysphagia. So this is why in patients who have dysmotility, you have dysphagia, you have to be sure that there is no dysmotility by manometry, and here is one of the important roles of manometry in the management of gastroesophageal reflux disease. Those patients who have dysmotility, it's better to tailor them another type of operation, which is the toupee type or 270 degree Nissen fundoplication, which is a complete wrap. You do your wrap posteriorly and you leave the anterior part without a wrap, permitting for the food and the peristaltic activity to act without a wrap preventing the passage. So Nissen fundoplication is a 30-60 degree wrap. Toupee or partial fundoplication is a wrap of 270 degree with the anterior part of the esophagus not wrapped by the fundus of the stomach. The anterior wrap, which is the door technique, it has not good results. 40% only of the patients are satisfied, and this is an obsolete operation not done nowadays for gastroesophageal reflux disease per se. Is there any other alternatives for the treatment of gastroesophageal reflux other than medical treatment and surgical treatment? Yes, there are trials to manage the gastroesophageal reflux endoscopically by doing radiofrequency at the gastroesophageal junction by the Streeter procedure, making some fibrosis and tightening of this area by radiofrequency. Many mechanisms of suture ligation and plication of the mucosa at the cardia can be done endoscopically. It's a very complicated technique which is still under trial. We can inject submucosal implantation of inert material at the enterics, which will tighten and make the region more competent and less wide, and links the system, which is a bracelet of magnets which together close around the lower esophagus. So this is the apparatus which is introduced through the endoscope to make plication of the gastric mucosa and or plication of the gastroesophageal junction. This is a stretta technique with radiofrequency and delivering radiofrequency, heat, and some sort of closure and fibrosis at this region. This is the injection of the enterics by injectors through the endoscope. This causes this area to be less wide and more competent, and this is the link system amalgam of magnets which together make this region closed at the gastroesophageal junction, permitting also passage of the peristaltic wave and the food bolus. Finally, to end, we have to mention the definition of the hiatus hernia. The hiatus hernia, we have two types or three types of acquired diaphragmatic hernia. We have the sliding hiatus, sliding hernia. We have the paraesophageal hernia, and we have a mixed hernia. This is a big sliding hernia which pull up part of the stomach, and this is a mixed hernia. It's a mix between sliding and paraesophageal hernia. It's rare. It's 5% of the cases. 10% are paraesophageal. 85% are. What we have to say that sliding hiatus hernia is most of the time accompanied by reflux, but some cases of hiatus hernia does not have reflux, and reflux does not mean that there is a hiatus hernia. So reflux to occur can occur without the presence of a hiatus hernia, and a hiatus hernia can occur without the presence of gastroesophageal reflux. That means that they are not synonymous, but it's a good association. There is a lot of cases of sliding hernia who have gastroesophageal reflux. This is the sliding hiatus hernia. This is the hiatus of the diaphragm, and part of the stomach slides upward in the chest, and this is the sliding hiatus hernia. So it's axial displacement of the gastroesophageal junction above the diaphragm, and the gastroesophageal junction is above the diaphragm. The high pressure zone is above the diaphragm. This is why it's most of the time it is associated by reflux disease. So it can have a hernial sac, and the contents is cardia and fundus. The clinical picture, 50% of the patient are symptomatic. Some of them have gastroesophageal reflux symptoms of heartburn, regurgitation. They may have dysphagia either by the effect of the hiatus hernia obstructing and impeding the motility of the esophagus, coughing and choking due to reflux, and the complications are less common and mild than paraesophageal hernia. So the gastric rouget are seen on barium above the diaphragm. There is upward displacement of the esophagogastric junction. This is important, and there is absence of fundic air bubbles. This is another barium of the sliding hiatus hernia. We see part of the stomach above the diaphragm, and the gastroesophageal junction is displaced upwards. This is the endoscopic picture. The Z line, which is the gastroesophageal junction, the line of junction between the gastric and esophageal mucosa is elevated or is pushed upwards. It appears on retroversion. You have this is the diaphragmatic crura, and this part of the stomach which is slided upwards, and this is the endoscopic picture. This is another endoscopic picture. This is an antegrade view. You see this is the Z line, the line of junction between the esophageal mucosa and the gastric mucosa. This is the cardia, and we see that this is part of hiatus hernia. All this is part of the stomach, and all this is hiatus hernia, and we are sure that this is the stomach because we have rouget. This is the esophagus. We don't have rouget, so these are the rouget of the stomach, and we are sure that this is a part of a hiatus hernia. This is on retroversion. You see that there is ascent or displacement or sliding up of a part of the stomach in the chest, and this is the barium meal showing displacement of part of the cardia and the fundus in the chest, with the gastroesophageal junction displaced upwards. On the other hand, the paraesophageal hernia, you have the gastroesophageal junction anchored in its place. It does not slide up, but part of the stomach, due to widening of the hiatus, can herniate near the esophagus upward into the chest, and this is the paraesophageal hernia. So in a paraesophageal hernia, the gastroesophageal junction is in its place. It is part of the stomach which herniates, and when it is large, it may allows some of the small intestine or the colon to herniate upwards in the chest. So it's a true hernia. The esophagogastric junction is undisplaced from its normal position in the abdomen. All or part of the stomach herniates into the chest. The contents stomach may contain intestine or the colon, usually not associated with gastroesophageal reflux disease because the gastroesophageal junction is competent and present in its place. We can say this is paraesophageal hernia or rolling hiatus hernia. Presents the clinical picture, it presents late when large enough to cause pressure symptoms. Most of its symptoms are due to pressure on neighbor organs, dysphagia if it press or compress the esophagus. On the heart, there may be palpitation or arrhythmia. It has some complication, volvulus, bleeding, because there is peptic ulcer which can occur in the region of the paraesophageal hernia, obstruction or strangulation from the volvulus, and this may, if strangulation occurs, perforation can also occur. This is the plain X-ray chest showing fundic air bubbles and intestinal gas in the chest. This is the barium meal showing part of the stomach upwards in the chest, but the gastroesophageal junction in its place. This is paraesophageal hernia with some sort of volvulus, with mesenteric axia, with mesenteroaxial gastric volvulus. This CT shows the heart, and posteriorly there is part of the stomach. This is the endoscopic view showing the cardia at its place, and nearby it there is protrusion or propulsion of part of the stomach into the chest. This is another view of endoscopy. This is the hiatus. This is the antegrade view with the esophageal junction in its place, but on retroversion you have part of the stomach herniating through the diaphragm, the crura of the diaphragm, into the chest. The treatment: mobilization of the hernia, reduction of the hernia. If there is a sac, it should be reduced, reduction of the contents, and repair of the defect of the crura by interrupted sutures, and gastropexy by doing a Nissen fundoplication wrap. So, gastroesophageal junction in a sliding hernia, it's intrathoracic because it slides upwards, but in the rolling or paraesophageal hernia, it's intra-abdominal. The mixed one, it could be one of both. Content cardia fundus, this here fundus and body, and gastric volvulus does not occur here, but it can occur in paraesophageal and mixed hernia. So this was the last slide of this topic. Thank you for attention. Thank you.